7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach for Neurosurgical TV. We're doing a conference on normal pressure hydrocephalus. First, let's start off right away with Michael Sughrue. I hope I pronounced that right, Michael.
Well, it's Sughrue. I've been mispronouncing it my whole life, so don't worry.
Okay, I'm sorry about that. Okay, from Oklahoma and currently in Australia, and maybe Michael can tell us a little bit about where he's from and then launch into his presentation. Welcome, Michael.
Welcome, everyone. And my talk today, when I was asked to speak about NPH, I'm going to talk about our goal, which I think one of the things that's been inadequately addressed, is the idea of finding a ground truth. And so what do I mean by that? What I mean is that it's easy in NPH relatively to do the surgery. There's a lot of ways to screw up shunts, but again, when it comes down to it, what the most challenging thing we face is deciding who to put those shunts in or what procedures to do on what patients. But when we meet a patient, what we know are the symptoms, which often are nonspecific. There are a lot of things that can cause cognitive problems and balance problems, for example. And we know they're imaging. We might know that there's ventriculomegaly, but we can't be certain it's not atrophy in most of the patients. This isn't really what we need to know. What we want to know is, will they get better if we push it through some kind of procedure? And that's not something that we get the standard pathway. Can someone mute their mic?
Yeah, I'm sorry. I'm sorry. Yeah, let me take care of that. I'm sorry.
Oh, no worries. So what I always stress to my trainees is that one of the things that we have to focus on is that chronic hydrocephalus is not a radiographic diagnosis. It's a collection of symptoms, which involve some combination of cognitive decline, particularly ataxic or magnetic gaits, but these can be very hard to nail down specifically, urinary incontinence, papilledema, or other sort of CSF-related symptoms. This may or may not have ventriculomegaly, and it may or may not respond to CSF diversion, even if it's hydrocephalus. So this, again, it's a clinical diagnosis, at least in 2018. It's not a radiographic diagnosis, but this is something people spend a lot of time trying to figure out how big the ventricles are. But the truth of it is, what we really want to know is the shunt going to help the patient? And there's a lot of reasons when we think about why people fail that we really need to start thinking about. And this is where we get when we get into the concept of finding a real true ground truth diagnosis. We can be seeing atrophy, but not hydrocephalus. The white matter could be damaged from chronic compression, or we may be treating a disease that is not hydrocephalus, or even could be comorbid with hydrocephalus. And many of these diagnoses require an autopsy, for example, Alzheimer's disease. So again, we need to sort through the patients and figure out the ones who are going to be likely to respond. And it's important to get this right, because if we agree that radiographic findings are not diagnostic of NPH, then how do we know if the shunt's blocked? Because again, you need to know that this was probably supposed to work in the first place. So people have tried lots of different trials to try to get at this, and these are invasive trials like provocative drainage trials. Certainly this is much better. Things like lumbar punctures, or a TAP test, when some people call it, more long-term drainage trials like lumbar drains and ventricular drains. I personally like the EVD, and the reason I like it is because some people need longer and more aggressive drainages than you can do with an LP or even with a lumbar drain. And so you oftentimes, if you think about some of these patients who've been dilated for a long period of time, you do need to drain them down for quite a while for them to establish their normal turgor and for the symptoms of the compression to be relieved. So what we really want to do is, given how beneficial this is in the right patient, we don't want to pass on people who respond with a better drainage paradigm. But the biggest thing we found in these trials is we need to make sure that these patients are adequately drained. And it's not possible to ensure that these patients are adequately drained by doing a single test. But the question is, given that provocative drainage trials are invasive, what would a perfect test look like if we were moving past that? And I want to throw out some ideas in this talk, what I have left of this talk, to discuss this. And ultimately, we need to get back to the simple, most likely pathology of how hydrocephalus causes the triad of symptoms that we tend to see in NPH. And basically, the majority of these most likely come from compression of the periventricular white matter. And again, mostly the frontal white matter from the frontal horn. More severe cases can be more widespread, but this is the best hypothesis that I know of on what's going on. And the two key questions that a perfect test should answer is the white matter actually damaged, yes or no? And are the frontal parietal networks that are linked by the periventricular white matter dysfunctional? Are they not working? Because again, if someone has atrophy-related dementia, a shunt is not going to fix this. So we need to have a better test than this. And so my research is heavily into connectomics. And there's a lot of different aspects of this, but really in short, it's a big data analytic technique for functional MRI or diffusion tensor imaging. It's easy to acquire. Anyone can get it on almost any scanner that's been made in the last 10 years or so. And there's a lot more data there, and it really comes down to post-processing it. But you can make very beautiful images looking at periventricular white matter like we see here. But the question is, how do you know whether the white matter's been damaged? And this is a $1 million question. But some ideas that have been put out there. It's hard to say that you're usually not going to see fiber tracts completely missing. And usually when you do see that, this is actually an artifact of your processing technique. People have proposed using the fractional anisotropy or FA map as a measure of injury, but the issue is we don't know what normal values look like for various white matter tracts. This is not well described, so we don't know when it's abnormal. And it's really highly dependent on how you model the FA map. More exciting, and I think probably the answer to this is a new technique called susceptibility weighted imaging. It's more specific, but this is a much longer acquisition time because you have to acquire 2 non-zero B value scans. So this is almost doubling the scan time. But it really shows a lot of promise for answering that question. Now, the question about whether the frontal parietal networks are not working can really, I think, get better at with things like functional MRI, like resting state. And how you would process this is you would basically pull ROIs that are usually supposed to be synchronized, compare them, and you can get metrics on how out of sync or dysfunctional these are. So if you look at something like independent component analysis, what this is a method of, let's say these gentlemen were all having a discussion at a cocktail party. What it does is it looks at the different waveforms picked up from different parts of the room and figures out who's talking to who. And you really can do some powerful things with this technique, mainly pulling out the canonical ICA networks. And given that I have 10 minutes, I don't have time to go into this. But basically, you can get pictures that look like this, looking at various networks. The default mode network is a typical one that we should be looking at. But this is probably the network that's most dysfunctional, this frontoparietal network here, that the white matter pathways are running over the ventricle. And so there are techniques. One is called dual regression, where you can look at the correlations of different nodes of the ICA network and possibly use it as a metric. Now, again, the last thing about it is what I think is a really exciting possibility, which is taking all of the white matter pathways, mapping them into a grid, and then simulating them with data. So this is a platform where we take a DTI graph of the brain, and what you're seeing here is a coupled set of differential equations constantly being solved at every point. And so this is really more what the future, I think, looks like for how do we go at determining is the brain dysfunctional from the problem that we think. So in short, treating NPH is about putting the right shunts in the right people and doing that correctly. I talked about the first part. I think many people are going to do a much better job of talking about how to put them in correctly. Provocative drainage trials right now are the best that I think we can do, but I think we need to improve our diagnostics for